Actually, I'm going to roll back and I'm going to ask you something on that in a minute, Suchi. But the one of the audience questions, and I want to make sure that we have a chance to respond to the audience questions coming in, is related to actually one of the first questions I was going to ask, which is what makes an algorithm trustworthy? You talked about this issue of doing some anthropology and socialization of the tools, and actually the key issue of aftermarket vigilance is often sort of ignored, that drives systems into local minimums. And this sort of pushes us back to a notion of online learning issues. And so there comes a question of what makes the machine learning algorithm trustworthy, and how do we know its explanatory power for the disease process is appropriate, and what are the barriers to clinical acceptance here? The audience question actually was, how do you recommend handling model generalization and drift when implementing a machine learning solution at different hospitals? But I think this is part of the same question. We don't know what the future data is. So maybe Suchi, you can go first on that and riff off your thought process there.
Sure. So there were a lot of questions there, Gary. So I'll try to be succinct and kind of pick and choose. So first question, really simple, is I think an audience member asked, how do you think about drift and robustness, and as you move from one setting to another, etc. So I'll do a cop-out answer, which is, I think these slides will get posted in the slide. There's one invited article that was in Biostatistics called Shift Stable Models. That does a bit of an overview from machine learning standpoint of where the field is, and there are hundreds of algorithms, even just in that space, hundreds of papers in that space alone about how to think about it. And some really, really good ideas in the field now. So, and then otherwise, just send me a note and I'd be happy to point you to very specific papers and pointers in order to think about it. Moving beyond that, I think Gary asked a very interesting question, which is, how do you think of trust? And what is trust? And how do we build trustworthy, how do we build trustworthy algorithms? So to me, I think this is obviously a very, very hard question. And I think I'm leading a large program that's funded by NSF on this notion of building high quality human machine teams. And how do you build, because, you work very well with a collaborator you trust. And when you've developed a mental model for them and you've learned how to trust them, you can be very effective together. So the question is, can we similarly build effective human machine teams? And what are the ingredients of work in building human machine teams? So it's a very big topic, an interesting topic in its own right. Some really simple, intuitive things. If the algorithms are telling you things that are bogus in ways that you don't understand it, and it blindsides you, you're going to have a tough time trusting it, right? So that's an example. So it's not just the fact that it's wrong. It can be wrong, but if you knew it's often wrong in that scenario, you may still be willing to trust it because maybe it's right in other scenarios that you find very important. But if it behaves in ways that you find unpredictable and you find you have a hard time understanding what it's doing, why it's doing, and it's blindsiding you, then you're going to have a hard time trusting it. So there is a sequence of those kinds of metrics that you can, optimize against, but also put end-to-end processes in place in order to do monitoring. So it's not just sort of one algorithm that's frozen. There are monitoring algorithms to monitor the performance over time. Anyway, I'll pause.
Thanks, Suchi. I think that's there's another question that sort of follows on from that, which I think I'm going to bounce to Shamim first, and it plays into this last question as well. So we might address something in that, which is you're predicting through time, and you're going to have reactions from patients, and you're going to have reactions from clinicians, and in some sense, you want to feed that back into the model. So what's the best framework? What's the right way for feeding that back into the model and then assessing how well that's performing?
That's a very good question, and I think it's a very difficult question. In fact, I defer to Suchi because she was one of the first who wrote about counterfactual predictions, asking the questions of what if in this context. What if, I give this drug to this patient, or what if this and that. But in my own work, we intentionally try to stay away from incorporating medications, for instance, into the algorithms or clinician behavior into the algorithms, because you can get yourself into this circular loop that the algorithm is saying that the patient is sick, and then the clinician gets worried about that and orders extra tests, and the algorithm notices that pattern in the data, and the risk score increases, and suddenly you get a very, very high risk score. It becomes a self-fulfilling prophecy. The answer is you have to be very careful and you have to do it systematically. That's all I can say.
It's a good sidestep. Maybe, Raj, I can ask you to comment about the sort of the human factors aspect of that and how that plays into it.
Yeah, I mean, so generally, just carrying on these comments around trust, there's a huge body of literature on this, and in the aviation domain in particular, they've been grappling with this issue for a very long time of trust in automation and technology, and I think this the concept of sort of artificial intelligence or bots as team members also has been dealt with really extensively there. So I would say we certainly don't need to reinvent the wheel, and we should be looking to that literature to understand the concepts and bring into healthcare whatever is required there. And I think it really comes down to one of the issues that we've talked about briefly, which is confidence levels in those models and in those alerts. Because certainly, if we think about our personal relationships, how we build trust, there's this element of being able to anticipate or predict what another individual is going to do, and that's one part of trust. In this case, if we could predict what the model is going to do, therefore the model is essentially useless, right? We want these predictive models because they're illuminating or shining a light on something that we may be missing. That's missing from our sphere of understanding potentially. And so the trust elements here are a little bit different. We need to simply think through those concepts, I think. And again, I'll just encourage us to look at the literature from aviation and extract what we can there.
Thanks, Mike. I'm going to give Chris the last word because this all drives us back to the quality of the data and how we might integrate the variations in quality into these kind of prediction metrics. And I was wondering if I could tease something out of you on that, Chris.
Yeah, it's been a thorough discussion on this point. I think we've gone from different types of models to use to then what does it mean to trust the answers of those models. I'll go back to the overarching purpose, though, of the model needs to guide even the discussion. So if we're seeking to nudge clinician behavior, and the end user as a clinician, that's also very different than if we're seeking to change a clinician-patient interaction. So we haven't mentioned patients in this little panel, and we can't ignore that they're involved in those decisions too. The user, whether it's the nurse or the doctor at the bedside, isn't acting in a vacuum. I guess I'll leave it there and say we have a lot to learn.
Thanks, Chris. Thanks for bringing it back to the patient. It's a very important point. Well, thanks again to all my panelists. I really, it's a privilege to have been on the panel with you, and thanks very much for your time. Back over to you, Emory. Thanks.